Okay, so for our last two talks, we're going to talk about abnormalities of situs and cardiac malposition. So this is a very complicated topic, and that's why we save it for last. And the idea here is to have a systematic way of approaching cases where it's a very strange-looking heart, right? So if you have a case like this, how do we approach a case like this? What can we say about this? So we need some kind of systematic approach. So you look at this and you can be very confused. Here's another case. You look at this and things are very confusing here. So how do we figure this out? What approach do we use? And that's what we'll hopefully go through. So we'll talk about the morphology of cardiac chambers. All of that is familiar to you, so we'll go through that quickly. Situs, disorders of heterotaxy, we'll talk about that. The embryological principles, which is really the key to understanding our systematic approach. And then we'll talk about cardiac malpositions. And then the approach to complex congenital heart disease, the von Praagh segmental approach. And that really is a very simple, systematic way of approaching these cases. And then we'll talk about causes of dextrocardia in adults. Now, we've discussed this already. How do we differentiate the morphologic right atrium from the morphologic left atrium? The answer is?
IVC.
What? Yeah, so the IVC takes you to?
The right atrium.
Yeah, the IVC takes you to the morphologic right atrium. What about the morphology of the atria itself? What's different? What's different about the morphology of the right atrium versus the left atrium? Well, a little bit, but what's different about the atrial appendages? The major difference there is what?
One's triangular and widened.
So which one is tubular?
The left.
Yeah, the left atrial appendage is tubular, right? So that's the major difference in the appearance of the atria. The right atrial appendage has a wide ostium. The left atrial appendage has a narrow ostium. So the right atrium receives blood from the SVC-IVC coronary sinus. The IVC is the most important. You follow that, it will take you to the right atrium. So for the right atrium also receives the coronary sinus. So if you can find the coronary sinus, that's going to take you also to the right atrium. We have pectinate muscles there in the right atrium, but really it's the morphology of the atrial appendage that's most important. Conduction system, the AV node, is also found in the right atrium. That's not something, though, that we're going to be able to see radiologically. The left atrium, normally it receives the pulmonary veins, but the most important difference is that narrow ostium for the left atrium, and that's why the left atrial appendage is the common location where you get clots when you have atrial fibrillation. So when we look at the left atrial appendage, we see that it's tubular and has a narrow ostium. And here it is on the axial view, and that's a major difference in morphology between the left atrium and the right atrium. It's another nice two-chamber view showing you the shape of, and then on this volume render view, the shape of that left atrial appendage. How do we differentiate the right ventricle from the morphologic left ventricle?
The right ventricle, that's the moderator band?
Yeah, so the moderator band is a feature of the right ventricle. What's the most important difference between the morphologic right ventricle and the left ventricle? The infundibulum, right. So the muscular outflow tract of the right ventricle, which separates the inflow from the outflow valve. For the left ventricle, we have what's called what? The inflow valve and the outflow valve, are they separated by musculature? The phrase we use is fibrous continuity for the relation of the inflow and outflow valve. Now, why is it important to differentiate, what's morphologic right, what's morphologic left? Because, you would say, well, the right atrium is on the right side, the left atrium is on the left side. That's not always the case. And when you get into complex congenital heart disease, the morphologic right atrium can be on the wrong side. The morphologic right ventricle can be on the wrong side, but you have to be able to differentiate the morphology of the ventricles. Otherwise, you wouldn't be able to realize that. So that's the point of anatomic versus morphologic, the morphology of the chambers, right? So the right ventricle is usually to the right of the left ventricle, the morphologic right ventricle. But there are congenital heart diseases where it won't be. You have to be able to differentiate the morphology of the ventricle so that you'll be able to tell if it's in the correct, if it's on the right side or if it's not on the correct side. So the right ventricle itself, the inflow valve is a tricuspid valve. It has 3 leaflets. The most important difference is the outflow tract, the infundibulum, which separates the inflow valve from the outflow valve. That's the most reliable characteristic of the morphologic right ventricle. Tends to be more trabeculated than the left ventricle. You mentioned the moderator band. That's also an anatomic finding that we see within the right ventricle. For the left ventricle, the inflow valve and the outflow valve share the same fibrous skeleton. So if you follow the anterior leaflet here, the mitral valve, it takes you to the aortic valve. So that's called fibrous continuity. So they're not separated there. There's not a lot of space between them. Okay? So that's a feature of the morphologic left ventricle. Also tends to have better formed papillary muscles. So when we look at the right ventricle, that muscular outflow tract is the infundibulum. That sits below the outflow valve, the muscular outflow tract. That's the most useful feature for identifying the morphologic right ventricle. So if we look here, here's the inflow valve, here's the outflow valve. They're separated, and then this infundibulum is the muscular outflow tract that you can see nicely demonstrated there for the morphologic right ventricle. You mentioned the moderator band, right? So what's a nice way to think of the moderator band? It's a trabeculation that connects the interventricular septum to the anterior free wall of the ventricle. That is what the moderator band is, okay? And that's usually something that's a feature of the morphologic right ventricle. So that can also help you to identify the morphologic right ventricle. Another important feature of the morphologic right ventricle is that the septal leaflet of the tricuspid valve is displaced slightly more towards the apex of the right ventricle, towards the apex of the ventricle, than is that septal leaflet of the morphologic left ventricle. So you see here, they don't line up perfectly. This one, the septal leaflet, is displaced a little bit more towards the apex. Right? So that means that you have this little area here. Well, first of all, if this is too far towards the apex, what do we call that? Epstein's, right. So that's Epstein's anomaly. But that means that there's this little area here, you see, that's called the atrioventricular septum, and that can separate the atria here from, in this case, the right atrium from the left ventricle. And there is a rare congenital heart disease where you can get a hole right there, and then you have direct communication between the left ventricle and the right atrium. What do we call that? That's a Gerbeau defect, right? Okay. So the 3-chamber view nicely demonstrates fibrous continuity. If you're looking at a morphologic left ventricle, here's the inflow valve, here's the outflow valve. They're very close together. They share the same fibrous skeleton. All right? And then usually the papillary muscles are better formed on the left ventricle, but that's really not what you're going to use if you're trying to differentiate the morphology of the ventricles. Right? So in summary, when you're comparing the morphology of the ventricles for the right ventricle, we have separation of the inflow valve from the outflow valve. There's a muscular infundibulum there. Also, you might find the moderator band in the right ventricle. For the left ventricle, fibrous continuity. The inflow valve will take you to the outflow valve. They're not widely separated. All right? This is something else that you also need to bear in mind, the normal relationship of the pulmonic valve relative to the aortic valve. So what is that relationship? What's the normal anatomic relationship of the pulmonic valve to the aortic valve?
Superior, anterior to the left.
Anterior, superior, and to the left. So somebody should be able to call you at 2 in the morning and ask you that question. You shouldn't have to think about it. That's got to be a reflex, okay? Because that's also something that we're going to look for when we're looking at congenital heart disease. So the pulmonic valve is anterior, superior, and to the left of the aortic valve. Okay, so we know that's normal. So you have to realize that when we're looking at these cases. Now we get into the nitty-gritty. Situs. What is situs? We were talking about, in general, if we're talking about this term situs, what do we mean? What are we talking about if we say situs? In general, what are we talking about? How do you understand that? If somebody says the term situs to you, how do you understand that? What are they talking about?
The orientation.
Yeah, so it's the configuration of organs in the body, especially asymmetric organs, right? Nobody talks about situs of the brain, right? The brain's a symmetric organ, right? But we have asymmetry within the abdomen, mainly the what?
The liver,
The liver and the spleen. We have asymmetry in the chest. We have what?
the heart valves,
Outside the heart. What's asymmetric in the chest?
lobes of the lung.
The lobes of the lung, right. You have the trilobe lung that's on the right. You have the bilobe lung that's on the left. So it's the configuration of that. So certain configurations of that we would characterize as situs. And so we know these terms, situs solitus, right? That's the normal configuration, situs inversus. That's usually we think of that as just a mirror image of normal. And then we have the situs ambiguous syndromes or the heterotaxy syndromes, and we'll talk about these too, asplenia and polysplenia. So if you come across a case like this and trying to decide what's the situs of this, well, this is something a little bit difficult to figure out, right? It looks like we have a symmetric liver here in the middle. What's going on with the heart, we don't know. So this may fall in that category of situs ambiguous. Okay, and then you have to know to think about these syndromes here. So when we're talking about the heart, though, if we're talking about the heart itself, the situs of the heart, as it refers to the heart, refers to the atria. We're really talking about the atria, not the ventricles, because the atria differentiate into morphologic right and left very early on during embryology. The ventricles take their positions later. So if we're talking about situs of the heart, we're talking about the atria. Now, what does this mean? This means that there's usually visceral atrial concordance between the atria and the other organs within the body. So the right atrium that will differentiate at the same time, as the IVC, and then the left atrium as is happening with what's going on with the blood vessels within the lungs. So the right atrium is found on the same side of the body, usually, as the liver, the eparterial bronchus. And you're going to have to know what those terms mean because these are very nice examination terms. The IVC and the trilobe lung. Right? So the morphologic right atrium is usually found on the same side of the body as those guys. The morphologic left atrium is found on the same side as the stomach, the hyparterial bronchus, the descending aorta, the bilobe lung, and the spleen. Of these, the most important organs for the right atrium, usually on the same side of the body as the liver and the trilobe lung. For the left atrium, usually on the same side of the body as the bilobe lung and the spleen. Okay? So situs solitus, if we use the term situs solitus, well, we know this is normal, right? So what do we mean by that? We mean that the morphologic right atrium is to the right of the morphologic left atrium, and we have normal position of the heart and viscera, the cardiac apex, gastric bubble are usually on the left side, right? There's a quick way of looking at the chest radiograph. We identify that as normal. If the stomach or the apex is not where we expect it to be, then all of the bells go off that, gee, there's something wrong here, okay? So situs inversus, if we use that, it means that the morphologic right atrium is to the left of the morphologic left atrium. So usually the cardiac apex and the gastric bubble are on the right side. The mirror image, situs inversus totalis, is the mirror image of normal. So in this condition, the incidence of congenital heart disease is low if you have situs inversus totalis, corrected transposition being one of the more common ones, but it can also be associated with Cartaginer syndrome, and we know that with situs inversus, bronchiectasis, and sinusitis for Cartaginer syndrome. All right, so we're kind of familiar with this. Situs solitus, that's just normal. We're used to looking at that. Situs inversus, that's the mirror image of normal. So when you look at the chest radiograph, right, how do you know that that's situs inversus? How do you know when you look at the chest radiograph that this is situs inversus? How do you know? Well, not right. It's not the heart, the liver. You notice that the liver here is on the left side of the body. The liver's on the wrong side of the body. Okay? So the liver's on the opposite side. So as far as the abdominal organs go, it looks like this person has situs inversus, right? So then we would imagine that the lungs and the heart would go along with that if we have a case of situs inversus totalis. So look at the abdomen first when you're dealing with these cases of trying to figure out these cases of abnormal situs. Now, what about situs ambiguous? So here, there's an abnormal visceral-atrial relationship. It's heterotaxy, right? So everything that we expect to be on the same side is not on the same side. That's heterotaxy. They're in abnormal locations. So usually in this case, we have these situs ambiguous syndromes where there's a common atrium where both sides of the atrium tend to resemble the same morphology or have similar morphology. So you can have bilateral right-sidedness or asplenia, or bilateral left-sidedness or polysplenia. Okay, and we recognize usually on the plain film we might recognize situs ambiguous as in many cases the liver is kind of symmetric and in the middle. The heart is kind of confusing when you're trying to figure out, what's going on here with the heart. Sometimes the heart also might be in the middle. It could be on one side or the other. But usually when you look at the abdomen, it looks like you have that symmetric appearance liver. That's usually a tip-off that you're dealing with the situs ambiguous syndrome. So what do we mean by the morphology of the atria here? Well, we know about situs solitus, right? Here's your morphologic left atrium with that left atrial appendage. There's your morphologic right atrium. Situs inversus, just a mirror image of that, no problem. But right isomerism, that's the other term for bilateral right-sidedness, where these atria, both atria here, morphologically resemble right atria. So that's bilateral right-sidedness, or asplenia. Bilateral left-sidedness, or polysplenia. So here, the morphology of both atria here kind of resemble left atria. See, you have left atrial appendages there. Okay, so these are the situs ambiguous syndromes. So with asplenia, what tends to happen is, both of these, you might have a symmetric midline kind of appearing liver. With asplenia, we say bilateral right-sidedness. You tend to have bilateral trilobe lungs. Okay. With polysplenia, you have multiple spleens. You tend to have bilateral bilobe lungs, bilateral right-sidedness here. And the atria tends to have right atrial morphology on both sides, and here the atria tends to have bilateral left atrial morphology on both sides. Okay? Now, if we're talking about asplenia versus polysplenia, which is worse? Which is worse, asplenia or polysplenia? Well, look, I mean, if you had a choice between having too many spleens or not having any, right? First of all, right there, you're better off, having to. But it's because of the associated congenital heart diseases, all right? Asplenia tends to be associated with very severe congenital cardiac malformation, so that's diagnosed in infancy. Polysplenia tends to be associated with milder congenital heart defects, so that you might run into in older patients, okay? The congenital heart disease that you have to know that is associated with asplenia is what? You're asked the exam question, comes up a lot. The congenital heart disease that has a strong association with asplenia is which one? Total anomalous pulmonary venous return. Right. That's the one you need to know. Okay. So asplenia syndrome, agenesis of the spleen, the clinical question, how jolly bodies in the erythrocytes, also called Eimark syndrome. Patients usually have a common atria, complex cyanotic congenital heart disease, decreased pulmonary vascularity, high mortality, total anomalous pulmonary venous return. But they can have other complex congenital heart diseases also, but that's the big one there, total anomalous pulmonary venous return. So bad congenital heart disease is associated with asplenia. And with asplenia, bilateral right-sidedness, bilateral trilobe lungs, the atria tend to resemble right atrial morphology, liver might be in the midline. So bilateral eparterial bronchi. So what does that term mean, eparterial bronchus?
The right-sided bronchus.
Yeah, but that's a bilateral right-sided bronchus, but what does that term mean, eparterial? The bronchus is, what's its relationship to the pulmonary artery on that side? Above or below? Above. Okay? On the left side, the bronchus tends to be below, the bronchus is below the pulmonary artery. Okay? The pulmonary artery on the left side, remember, goes up and over the bronchus. So on the right side, the pulmonary artery tends to be more inferior than the bronchus, all right? So that's the difference between eparterial bronchus and hyperarterial bronchus. Those terms you have to be familiar with. All right. Bilateral trilobe lungs, but could be bilateral SCC, absent or midline gallbladder, frequent hepatic symmetry, midline stomach, IVC and aorta tend to be on the same side of the body, and of course infants are at increased risk for sepsis due to the absence of the spleen. This is supposed to be illustrating here bilateral minor fissures, right? So bilateral minor fissures in asplenia, meaning we have bilateral trilobe lungs, okay? And then can be associated with severe congenital heart diseases. So which one is that?
Type 1. Type 1 all this.
Type what?
I think it's type 1.
Type 1, because you have the what? What sign is that? That's a snowman sign, right? That's autonomous pulmonary venous return, type 1, okay? So ipsilateral aorta and IVC, they tend to be on the same side of the body with asplenia. So here's an example here. So there's your IVC, there's the liver, there's the aorta. So they tend to be on the same side of the body in patients with asplenia. And here there's a common AV canal, a complete endocardial cushion defect in this case. This person with asplenia, all right? The morphology of both atria tend to resemble morphologic right atria. Right? You don't have well-formed left atrial appendage in either, or that tubular appendage that we associate with a morphologic left atrium, okay? And then we have bilateral eparterial bronchi. Here are the pulmonary arteries here. Notice that bilaterally, the bronchi here are above the pulmonary arteries, okay? So that's what we see. Now, polysplenia, this you might come across in adults. So if you have an adult with situs ambiguous, this is what you're going to be thinking about, polysplenia. Multiple small spleens may not have congenital heart disease or may have very mild acyanotic congenital heart disease. So the types of congenital heart disease that is associated with polysplenia are usually defects of in the, between the ventricles or the atria, atrial septal defects, ventricular septal defects, not the severe cyanotic congenital heart diseases that we see with asplenia. Okay. Bilateral left-sidedness, bilateral hyperarterial bronchi, meaning that the bronchus goes where? Below, right, the artery. Hepatic symmetry, common atrium, bilateral bilobe lungs. 84% of azygous continuation of the IVC, large azygous vein. Remember we said we want to follow the IVC because the IVC takes you to the right atrium. Well, what happens if you have bilateral left-sidedness and you don't have a right atrium, right? Where does the IVC take you? There is no IVC. It's azygous continuation, right? So it's a nice way to put that together, to remember that. So polysplenia is very strongly associated with azygous continuation. So multiple spleens here, kind of symmetric looking liver in this case, right? Polysplenia with splenules. Hyperarterial bronchi, right? So the pulmonary arteries here on both sides are going above the bronchi here before coming down. The interlobar branches there coming down on each side. And then azygous continuation of the IVC, right? So the intrahepatic IVC is missing. So we'll have azygous continuation of the IVC. So you'll have a big azygous vein. In these cases, patients with polysplenia might have a big azygous vein from azygous continuation of the IVC. Here's your big azygous vein there that's going to go up and then drain to the superior vena cava in this particular patient with polysplenia. Okay. The atria tend to resemble morphologic left atria bilaterally. So you have bilateral, looks like that morphology of left atrial appendage, tubular appendages bilaterally. Okay, and in the pulmonary arteries here going above and then descending behind, bilateral hyperarterial bronchi, bilateral left-sidedness with polysplenia. So in summary, asplenia, right isomerism, eparterial bronchi, severe cyanotic congenital heart diseases, bilateral SVC, aorta IVC on the same side, both will be associated with malrotation. Polysplenia, bilateral left-sidedness, hyperarterial bronchi, usually acyanotic congenital heart diseases. bilateral SVC, strong association with that is continuation of the inferior vena cava. Both of these, though, can be associated with malrotation of bowel. Okay, so we might see that in both cases, asplenia or polysplenia. All right, so now let's talk about the heart development here. And so this nice little movie here goes through the embryology and illustrates it. So we have cells that form this, and then we're going to form these endocardial tubes, and then they're going to fuse to form this single heart tube. Okay. So there's our single heart tube, and now there are these portions of it. We're going to go into that. I'm going to go over that again, but these are the portions that will differentiate into the different parts of the heart. And then that's my favorite part of the video. And then the heart's going to start to fold, right? The tube folds like that, and that's a D loop, usually folds to the right. That's what D loop means in embryology. And then the atria kind of move behind the ventricles. And then that's how the atria wind up behind the ventricles in our final configuration of the heart. Right? So that's how we get from that primitive cardiac tube, and it's going to differentiate into the different chambers, and then that looping winds up with the atria moving behind. All right, so let's go over this again. So we have our primitive cardiac tube. It has these different components, right? So this part here, the common atrium, that's going to differentiate into the morphologic right atrium and the left atrium. This primitive ventricle, this part called the primitive ventricle, that will form the morphologic left ventricle. This part called the bulbous cordus, that will form the morphologic right ventricle, and then the truncus arteriosus, that will divide into the aorta and the pulmonary artery. Now, in most cases, normally, this will loop to the right, okay? So you'll see that the bulbous cordus winds up here. Remember, the bulbous cordus forms the right ventricle, primitive ventricle, which forms the left ventricle, winds up there, right? And the atria will continue on to wind up behind it. And so it's going to loop like that, usually when we have a D loop, right? The truncus arteriosus then differentiates into the aorta and the pulmonary artery. And we know our relationship of the pulmonary artery to the aorta, so that occurs normally from the division of the truncus arteriosus. So here's our primitive cardiac tube. To go over that again, we have the atria, we have the ventricle here that's going to form the morphologic left ventricle, the bulbous cordus, which is going to form the morphologic right ventricle, the truncus arteriosus, which becomes the aorta and the pulmonary artery. Normally, this loops to the right, and so the bulbous cordus of the right ventricle here winds up there to the right of the left ventricle. Then the aorta, then the atria will loop behind it. Okay. So another thing that happens is in early development, after formation of the D loop, notice that the cardiac apex is on the right side. What do we call it when the cardiac apex is on the right side? What's the term we use? Can you read? It's called dextrocardia. So during normal embryology, right, it's normal to have dextrocardia at some point in the embryological development. The apex is on the right side. What happens, though, is that at the end of the first month, the apex then moves into the left hemithorax. It migrates to the left, and then that's why we wind up with the cardiac apex on the left side, or levocardia, that normal appearance of the heart. Okay? So this is important when we talk about cardiac malpositions, how this happens. Okay, so what do we have here? So we've talked about in most cases, when this tube loops, it loops to the right. That's called a D loop, right? Looping to the right. However, there are some rare cases where it might loop to the left. And if it loops to the left, that's an L loop. Notice if it loops to the left now, the bulbous cordus here, which is going to form the morphologic right ventricle, winds up to the left of what's going to wind up being the morphologic left ventricle. Okay? That's from an L loop, looping the wrong way. Now, this is also important to realize. Remember that we said these atria are going to differentiate into morphologic right and left atrium. When we have a D loop, the right-sided atrium, whatever this right-sided atrium is, whatever that is, will connect to the bulbous cordus here, or the morphologic right ventricle. And the left-sided atrium here will connect to this guy, the ventricle, which will be the morphologic left ventricle. When we have an L loop, okay, if it loops the other way, again, this atrium on this side, regardless of what kind of atrium that is going to connect to this guy, which is going to be the morphologic left ventricle. And then this atrium here, regardless of what kind of atrium that is going to connect to that guy, which is going to form the morphologic right ventricle. Okay? So this always puzzled me, is how do we get atrioventricular discordance? I could understand regular transposition, that's just some problem that happens in the truncus arteriosus, but how do we get atrioventricular discordance? We're headed there. This is the key to how we get that, to understanding congenitally corrected transposition. Okay? So we have to understand these terms also. What do we mean by concordant versus discordant cardiac loop? So a concordant cardiac loop will form concordant atrioventricular connections. A discordant cardiac loop will form discordant atrioventricular connections. So what do we mean? What's concordant atrioventricular connection? That means what? What do we mean if I say concordant atrioventricular connection? What does that mean? The morphologic right atrium connects to the morphologic right ventricle. The morphologic left atrium connects to the morphologic left ventricle. If we have a discordant atrioventricular connection, what does that mean?
Morphologic left atrium with the morphologic right ventricle.
Yes?
Right atrium with the left ventricle.
With the morphologic, regardless of what side of the body they're on. Right? Doesn't matter what side of the body they're on. But you have a morphologic right atrium connected to a morphologic left ventricle. That is discordant. That's a discordant atrioventricular connection. Okay? All right. So what are concordant cardiac loops? If we have situs solitus with D-loop ventricles, then the morphologic right atrium connects to the morphologic right ventricle, and the morphologic left atrium connects to the morphologic left ventricle. So this is what happens in just about everybody. This is normal. This is what we're used to looking at. So we have situs solitus. What does that mean? The morphologic right atrium is on the right. The morphologic left atrium is on the left. The ventricles form a D loop. Okay? Now the morphologic right atrium connects to the bulbous cordus, which is the morphologic right ventricle. The morphologic left atrium connects to the ventricle, which becomes the morphologic left ventricle. These are concordant atrioventricular connections. Right? That's a concordant cardiac loop. Now, there's another concordant cardiac loop that you can have. What if we have situs inversus, right? Well, then the ventricles should loop to the left. If we get an L loop with the ventricles, now again, we have the morphologic left atrium connecting to the morphologic left ventricle, the morphologic right atrium connecting to the morphologic right ventricle. Okay? So this is what happens in normal. This is what happens in somebody with situs inversus totalis who has no congenital heart disease. Now, what are discordant cardiac loops? A discordant cardiac loop will form discordant atrioventricular connection. So what are examples of that? Well, let's start out with situs solitus. Right? Situs solitus, the right atrium is on the right, the left atrium is on the left. Normally, this should go a D loop. But what if it does an L loop? What if the ventricles do an L loop here? Then what happens is that the morphologic right atrium connects to what? The morphologic left ventricle. And the morphologic left atrium connects to the morphologic right ventricle. Now we have discordant atrioventricular connections, right? So this is the key to understanding how do we get L transposition. So with situs solitus, If we have L transposition, we have atrioventricular discordance. Okay? I haven't talked about what transposition means yet. The L, the D and the L, when we talk about that, refers to the cardiac looping, really. D and L refer to the cardiac looping. Okay? Now, there is another discordant cardiac loop that you can also have, right? So what if we have situs inversus and we form a D loop? Again, the morphologic left atrium connects to the morphologic right ventricle, the morphologic right atrium connects to the morphologic left ventricle. Okay? Now, even though this is rare, right? We know that congenitally corrected transposition is really rare, right? Or to have that in somebody with situs solitus. This is extremely rarer. Why? Well, how many things have to go wrong to get this? One. You have situs solitus. Instead of forming a D loop, it just forms an L loop. That's still rare, right? But how many things have to go wrong to get this? 2. So you have to have situs inversus, which in and of itself is rare, right? But on top of that, it also has to undergo a discordant cardiac loop, okay? So that's why you're almost never going to see, maybe once in your life, if you're lucky, you might see that, okay? Now we need to talk about the great vessel relationships, so these terms. Transposition, right? If we use the word transposition, what does that word mean? It means discordant ventricular arterial connections. Don't think about D, don't think about L, erase that. The word transposition means discordant ventricular arterial connection. What does that mean? That means what?
Right ventricle,
The morphologic
morphologic right ventricle to the aorta,
is connected to the aorta, and the morphologic
left ventricle.
left ventricle, regardless of what side of the body they're on, right? We're talking about the morphologic ventricle, not the anatomic, not anatomy as far as side. We're talking about morphology of the ventricles, okay? Right there, right? Now, we talked about normal, right? Pulmonary artery, pulmonary anterior to the left of the aorta, right? There's the inverted relationship, which is the mirror image of normal. So here, the pulmonary artery is still anterior, but instead of being to the left, it's to the right of the aorta, okay? With transposition, usually when you have transposition, the aorta winds up anterior to the pulmonary artery. If it's detransposition, the aorta is usually to the right of the pulmonary artery. With L transposition, the aorta is to the left of the pulmonary artery. Now, these terms, we use a shortcut, right? When we talk about D and L transposition, we're usually talking about situs solitus. So we say detro, the aorta is to the right, it's D transposition, the aorta is to the left, it's L transposition, as if it's the aorta that determines whether it's D or L, right? But the D or L does not refer to the aorta. The D or L refers to what? The loop. The D or L refers to the loop. It just so happens that, and it's fortunate for us because it makes it easier to read the cases, that if you have a D loop, the aorta usually winds up to the right side, and if you have an L loop, the aorta usually winds up to the left side of the pulmonary artery. Okay? So it's nice that that goes together. It makes it easy for us to remember. But the D and the L in this terminology is referring to the cardiac loop, not really to the aorta. All right? So normal pulmonary valve is anterior to the left of the aortic valve, or the pulmonary artery anterior to the left. We know that. The shortcut term for that, if we're describing, is, there's an abbreviation S. We'll get into that when we talk about the von Praagh nomenclature here. Inverted is if it's the anterior-posterior relationship really is inverted here. Or really what we're, not the anterior-posterior relationship, but we're talking about it's a mirror image of normal, right? So inverted means that's the mirror image of normal. So the pulmonary artery, instead of being to the left, is to the right. With transposition, with detransposition, the aorta is anterior. Remember, with transpositions, the aorta tends to be anterior to the pulmonary artery. With D, it's from a D loop, winds up to the right. With L, it's from an L loop, winds up to the left. And the terms there, D transposition, D transposition. Right? So normal, we know that. Inverted, the mirror image of normal. D transposition, aorta is anterior, usually to the right. L transposition, aorta is anterior, usually to the left. So this is the kind of the abbreviations that we would use if we're talking about, these are the abbreviations that we would use if we're talking about the relationship of the great vessels. Okay? And then on imaging, it's easy to tell the normal configuration, the pulmonary artery anterior to the left of the aorta. If it's inverted, if it's the mirror image of normal, pulmonary artery is still anterior, but it's to the right of the aorta. Okay? Now this term malposition, what does malposition mean? We tend to come across this. We talked about double outlet right ventricle, double outlet left ventricle. So malposition usually means that both great vessels arise from the same ventricle. And they tend to be side by side as opposed to anterior posterior. Right, so if we have that, we call that malposition. D, usually if it's a D loop, the aorta is to the right. L, if it's from an L loop, the aorta is to the left. So this malposition, usually we're talking about a double outlet ventricle. And the aorta and pulmonary artery tend to be side by side rather than have an anterior posterior relationship. All right. Now, concordant cardiac loops can have normal great vessels or can have transposition. Now we know that, right? So we have a concordant cardiac loop here in somebody with situs solitis. Most cases, these people are going to be normal. We're used to looking at normal. However, sometimes, rarely, they might have transposition. Right? So they could have, if they have transposition, they could have detransposition. So this transposition, right, is not the corrected form of transposition. This is the bad type. When you have two completely separate circulations, we've covered this, right? So hopefully all of you are familiar with that. Now, what happens though if we have situs inversus, right? And we have a concordant cardiac loop, an L loop with situs inversus. Again, if you don't have transposition, you just have an inverted relationship here. And these patients are normal from the point of view of congenital heart disease. They're just the mirror image of normal when you look at their imaging. However, they might also have transposition. They might develop transposition. If they develop transposition, we will call this L transposition. But we call this L transposition because the L refers to the cardiac loop. This is not congenitally corrected transposition. This is the mirror image of detransposition in somebody with situs solitis, right? So remember I said that the L refers to the cardiac looping. And it just so happens that the aorta being to the left side tends to also go along with that. But if we have situs inversus and an L transposition, that is the bad kind of transposition. That's not the good kind of transposition, okay? So that's kind of what we covered here, right? So L transposition in somebody with situs inversus is still the bad kind of transposition. It is not congenitally corrected transposition because the loop is a concordant loop. These are concordant atrioventricular connections, okay? So it's still a bad transposition. Now what happens with discordant cardiac loops? When we have a discordant cardiac loop, you pretty much always will also have transposition. And the type of transposition corresponds to the type of cardiac loop. So let's start with situs solitis with L loop. That is the discordant cardiac loop, right? So situs solitis, the right atrium is on the right, left atrium is on the left. We have an L loop here, so we form discordant atrioventricular connections. But because it's a discordant cardiac loop, these patients, embryologically, they also develop transposition. And so the morphologic here, the morphologic right ventricle then winds up connecting to the aorta, the morphologic left ventricle winds up connecting to the pulmonary artery. So this becomes congenitally corrected transposition. So in somebody with situs solitis, When we say L transposition, remember the L refers to the cardiac loop. That's congenitally corrected transposition. Right? We understand that. We've discussed this before in congenital heart disease, but this is the explanation for how you get this embryologically. Now, what happens, though, if we form a discordant cardiac loop here the other way? What happens if we have situs inversus with a discordant cardiac loop? Right? So again, we have discordant atrioventricular connections. We will have discordant ventricular arterial connections because these patients will also develop transposition. We call it detransposition. Why do we call it detransposition? Because the cardiac loop was a D loop. But this is also congenitally corrected transposition because you have atrioventricular discordance and ventricular arterial discordance. This will also be congenitally corrected, right? It's the mirror image of congenitally corrected transposition in somebody with situs solitis. Again, this is very, very rare, right? Congenitally corrected transposition. To see that, this is extremely rare. Why? Because now you have to have situs inversus and you have to have a discordant cardiac loop, right? Whereas here, you have situs solitis, you just need the discordant cardiac loop. Here you need the two rare abnormalities to occur together, okay? All right, so summary so far, your heads are about ready to explode, so let's summarize here. Hopefully you understand this. Concordant loops. A concordant loop is a D loop with situs solitis. Situs solitis, right atrium on the right, left atrium on the left. D loop, concordant atrioventricular connections, right? These patients, most of them are normal. They will have normal ventricular arterial connections. However, they might develop transposition, and that will be detransposition, the bad kind of transposition, okay? Now again, this can also happen if we have situs inversus with an L loop, and again, if most cases, even in that case, they turn out to have normal connections there between they have concordant atrioventricular connections, concordant ventricular arterial connections. So there, the relationship of the pulmonary artery and the aorta will just be inverted. However, they might develop transposition, which is again extremely rare, but we will call that L transposition, right? In that case, right? So that's an L transposition, right? And so in this case, though, that is the bad kind of transposition, right? It's not congenitally corrected. Discordant cardiac loops, we went through this. They will form discordant atrioventricular connections, whether it's situs solitis here or situs inversus, but they will also all have transposition. They will all form discordant atrioventricular connections, okay? And so if you have situs solitis, we will characterize it, or we will call it L transposition in this case with situs solitis. This is congenitally corrected transposition, so that's the good kind. And if they happen to have situs inversus, then again, they will have congenitally corrected transposition, even though we will call it detransposition, but because of the situs inversus, that is the good kind of transposition, okay? So discordant cardiac loops form discordant atrioventricular and discordant ventricular arterial connections. That is what gives you congenitally corrected transposition. And it's fortunate for us that the aorta, the position of the aorta conforms in just about all cases to the type of cardiac loop. So that's why we will call this detransposition here. We'll call that detransposition in this case with the situs inversus, but here, L transposition, what we're used to seeing more commonly in patients with situs solitis with congenitally corrected transposition. Remember, this is extremely rare. This is rare. This is really, really rare. Okay? All right. So the relationship of the aorta and pulmonary artery tells you the type of cardiac loop in both concordant and discordant cardiac loops. That shortcut method, if the aorta is to the right of the pulmonary artery, then the ventricles usually did a D loop. If the aorta is to the left of the pulmonary artery, the ventricles usually did an L loop. But remember, the DNL refers to the cardiac loop, not to the position of the aorta, but it's fortunate for us that they kind of go together. Okay? Now we need to discuss here, we have a few minutes, so let's get into this. Terminology for cardiac malposition. There are these terms that can be very confusing, but you need to be familiar with them, or if you're going to describe these cases accurately, at least you need to be familiar with them. Levoposition means that the heart is shifted further to the left than normal due to extrinsic factors. So here, the heart is completely shifted to the left. Is it because of congenital heart disease? No, in this case, it's because of, complete collapse of the left lung. It's an intubated patient who has a mucus plug. All right. So if the heart is completely shifted to the left because of extrinsic factors like left pneumonectomy, big pneumothorax, complete collapse of the lung, we call that levoposition. Okay? Shifted to the left because of extrinsic factors. Levocardia means that the cardiac apex is on the left side. We're used to seeing that, right? That's levocardia. Levocardia with situs solitus. We're used to seeing that, right? That is normal. That's what we're used to seeing. Now, if we have levocardia with situs inversus, that's a problem. Right? So that's called, the term for that is levoversion. Usually the gastric bubble and the cardiac apex, or when you have levoversion, the gastric bubble and the cardiac apex are on opposite sides. Again, that's a shortcut. So if you're looking at a chest x-ray, the apex of the heart is usually on the same side as the stomach bubble, right? So if they're on opposite sides, the bell's got to go off, you got a problem there. What's better to look at, though, is the liver, because the liver gives you some idea of the situs of the patient, right? So in this case, the liver here looks like it's here on the left side, right? So you would imagine, well, this patient, looks like this patient should have situs inversus, right? But the apex is on the wrong side, so something is wrong here, right? If it's situs inversus, the cardiac apex should be on the other side. So if you look at the configuration of the abdomen, and then you look at the heart, and it gives you some idea that something might be abnormal. Okay. So levocardia with situs inversus is levoversion. So what causes levoversion? Failure of terminal. There are two causes of this: failure of terminal migration of L-loop ventricles into the right hemithorax, or completion of terminal migration of D-loop ventricles into the left hemithorax. So what do we mean by that? So if we have L-loop ventricles, right? After it's done the L-loop, the cardiac apex is on the left side. This should then migrate to the other side, to the right side, to put the apex on the right side because it formed from an L-loop. If it doesn't do that, then the cardiac apex remains on the left side. Okay? Completion of terminal migration of the D-loop ventricles into the left hemithorax. Remember we said if we have D-loop ventricles, right? So these D-loop ventricles should migrate to the left side, but here we have situs inversus, right? So in this case of situs inversus, this migrated to the other side, and now the apex is wound up on the left side here, but it's opposite to, it's not where we'd expect it to be based on the situs of the abdomen, right? So when we have situs inversus and levocardia, that's levoversion. So that usually is associated with severe congenital heart disease. Now, the term itself is a misnomer. There really is no abnormal twisting of the heart. It's either it went to the side it was supposed to go, or it didn't go to the side it was supposed to go to. Okay? Dextroposition is if the heart is shifted too far to the right side because of extrinsic factors. So if you have a right pneumonectomy, hypoplasia of the right lung, dextrocardia, if the apex of the heart is on the right side, dextrocardia with situs inversus is situs inversus totalis or mirror image dextrocardia. So we've seen, all of us have probably seen a few cases of that. Right? So if we look at the abdomen, we notice the liver's on the left side here. Right? So this patient has situs inversus, and the apex is on the right side. That's dextrocardia. This is what we would expect to see in somebody with situs inversus. Okay? Dextrocardia, though, with situs solitis, that's a problem. That's called dextroversion. So that can result from failure of terminal migration of D-loop ventricles into the left hemithorax, or completion of terminal migration of L-loop ventricles into the right hemithorax. So we have situs solitis here, right? The liver's on the right side, but the apex should be on the left side. The apex is on the right. It's not where it should be in a patient with situs solitis. This is called dextroversion. So how can this occur? Well, failure of terminal migration of D-loop ventricles into the left hemithorax. So if we have situs solitis, D-loop ventricles, remember we said that in embryology, this should migrate to the left hemithorax. If it doesn't migrate, we get dextrocardia. Okay? Completion of terminal migration of L-loop ventricles into the right hemithorax. If you have situs solitis and you happen to form L-loop ventricles, then in embryology, this should migrate to the right side. And if it does, that will also give you dextrocardia with situs solitis, and we call that dextroversion. Okay? And that's the mirror image of levoversion. The problem when we have dextroversion or levoversion is that almost all of these patients will have some form of congenital heart disease. So if we recognize that if the apex is on the wrong side relative to what the situs of the patient should be when you look at the abdominal organs, or if the stomach bubble is on the opposite side of the cardiac apex, usually there's some severe underlying congenital heart disease. And if the apex is on and if you have situs inversus with the dextrocardia, situs solitis with dextrocardia, that is called dextroversion. Okay? And then mesocardia just means the heart is in the midline. These patients can have anything, although in most cases these patients are just normal. It's just kind of an anatomic variant where the heart is in the midline. The bulk of the cardiac apex, or the heart itself, is in the midline of the body. So here's a patient with mesocardia, had no congenital heart disease. So in most cases, these patients with mesocardia will have no congenital heart disease. All right, so continuing with our discussion, a few more terms I wanted to go over again. So when we use the term levocardia, so levocardia means that the apex of the heart is on the left side. That's what we expect, that's what we usually see normally. Dextrocardia means that the apex of the heart is on the right side. And of course, when we see that, then we're thinking about abnormal conditions if we see that. These other terms also confusing. So let's talk about what these terms mean. So the term dextroversion means that you have dextrocardia with situs solitis. So if we try to decide what's the situs of this patient, we see that looks like the liver here is on the right side, looks like the stomach bubble is there on the left, so we assume the liver is here. So this person should have situs solitis. And in a person with situs solitis, we would expect normal, we would expect the apex to be on the left side there, normally. But the apex is on the wrong side here. So we call this dextroversion, dextrocardia with situs solitis. Similarly, this term, levoversion, means you have levocardia with situs inversus. Again, looking at the abdomen, it looks like the liver is on the left side. And so this person, we expect, might have situs inversus. So in somebody who had situs inversus totalis, we would expect them to be the mirror image of normal. We might expect to see the cardiac apex on the right side, but it seems to be on the other side. So again, that strikes us as abnormal. So whenever the cardiac apex and the stomach bubble are on opposite sides, that's kind of a shortcut. We think that there's something really strange going on here. So the term for this is levoversion. So note that the stomach and cardiac apex are on opposite sides. So that's always a clue that there's something wrong. Okay. Now, how do we get this? We talked about the embryology before. Normally, after the de-looping, de-loop is the normal loop that the ventricles would take. The heart always starts out with the apex on the right side. So all normal hearts will have a condition of dextrocardia, but then it will migrate towards the left so that the apex then winds up on the left side. So during development, all normal D-loop hearts will start with dextrocardia, and then that apex migrates to the left to give you the normal appearance of the heart with the apex on the left side. So what happens with dextroversion? So dextrocardia with situs solitus, right? So how do we get this embryologically? Well, there are two possibilities. You can get it from failure of terminal migration of D-loop ventricles into the left hemithorax. So here we have a patient with situs solitus, right atrium on the right, left atrium on the left. The heart forms the D-loop, but remember what we said during embryology, this should migrate to the left side. If it does not, then the apex stays on the right side, and we will have dextrocardia with situs solitus. The other way this can happen is if we have completion of terminal migration of L-loop ventricles into the right hemithorax. So let's say again we have situs solitus here, right atrium on the right, left atrium on the left. But instead of forming a D-loop, the heart forms an L-loop. By the way, what do we call that? If you have an L-loop with situs solitus, that's called what kind of loop is that? From the last lecture? D-loop with situs solitus is a concordant cardiac loop. L-loop with situs solitus is discordant cardiac loop. That is not supposed to happen, okay? But if it does, then this would migrate to the other side, completion of terminal migration of L-loop ventricles into the right hemithorax. That could also give you dextrocardia with situs solitus. Since this is a discordant cardiac loop, you would also expect this person to have what?
Or EP.
Well, atrioventricular discordance, right? You can see that, right? And discordant cardiac loops with atrioventricular discordance almost always would also have what regarding the ventricular arterial connections? Transposition, right? So you would expect, what do we call that? If you have atrioventricular discordance and ventricular arterial discordance, we call that the whole thing we call is it the good kind of transposition or the bad kind? It's the good kind, and we call that congenitally corrected transposition. Okay? Discordant cardiac loop. So that's how, those are the two ways you can have dextroversion with dextrocardia, okay, or dextrocardia with situs solitus. Now, so we've gone through this. In the most common form, again, when we see that configuration, most of these patients will have congenital heart disease, okay, especially corrected transposition. And in the most common form, the right ventricle, right atrium remain to the right, left ventricle is though anterior to the right ventricle. And it looks as if you turn the heart, and the heart should be like this. It looks as if you kind of twisted it this way. Right? That's what that looks like. So that's why the term is a misnomer. I mean, dextroversion, that term implies that the heart twisted abnormally, but that's not actually what happened embryologically. Either it migrated the way it was supposed to, or it didn't migrate the way it's supposed to, all right? Now, levoversion, or levocardia with situs inversus. Again, there are two ways to get this. We start out with situs inversus, right? Left atrium is on the right side. The morphologic right atrium here is on the left side. Failure of terminal migration of L-loop ventricles into the right hemithorax. So if you have situs inversus, The concordant cardiac loop that you should have with situs inversus is what kind of loop? What kind of loop would you expect in somebody who had situs inversus? What's the concordant loop? L loop, right. That would be the concordant loop, okay? But if that happens, if there's L loop, you'd expect that to migrate to the right, okay? If it doesn't migrate to the right, then we wind up with this condition, levocardia with situs inversus. Now, the other possibility is if we have situs inversus, but the patient, but instead of an L loop, forms a D loop, right? So D loop with situs inversus is what kind of cardiac loop? That's a discordant cardiac loop, right? Now, that D loop you would expect to migrate to the left, and if it did migrate to the left, then you would have the apex on the left side. You would have levocardia with situs inversus. Okay, so those are the two ways you can get it. But again, here, right, what kind of, with a discordant cardiac loop, what kind of atrioventricular connections do we have? We have, are they concordant or discordant? Do we have atrioventricular concordance or atrioventricular discordance? Discordance, right. And discordant cardiac loops would also have what regarding the ventricular arterial connections? Discordant cardiac loops have transposition, right. So you will have atrioventricular discordance and ventricular arterial discordance. We call that whole thing congenitally corrected transposition, right. But notice that in this case it happened from a D loop because the patient started with situs inversus. We usually think of congenitally corrected transposition as L loop, but that's because most people have situs solitus. Right? So that's just a mirror image of that. Now, the approach to complex congenital heart disease, there is this segmental approach of von Praagh. This is if you're actually reviewing these cases, analyzing these cases, dictating these cases. This is the way you are supposed to approach these cases so that referring cardiac surgeon or cardiologist can understand your report. So we read from a veno-arterial sequence from the atria to the ventricles to the great arteries, and we've kind of been doing this all along. We read scans from the bottom up, okay? Remember, as I'm showing you these cases, we usually start with what?
Morphologic right atrium.
We start with the IVC because that takes us to
Morphologic.
yeah, so that's how you begin. So the first thing we want to decide is the visceroatrial situs, right? What is the situs of the patient? You get an idea of that if you look at the abdominal organs, right? Because the atrial situs, as we've said, usually follows the abdominal situs. And you have three choices here. You can have situs solitus. What does that mean? Not the ventricles. When we're talking about situs for the heart, we start with the atrial situs because that follows the situs of usually the rest of the organs, the abdomen, right, the lungs. So that means situs solitus means that your liver's on the right, the spleen's on the left, the morphologic right atrium is what side? On the right side. Morphologic left atrium is on the left side. Now we've gone through how we differentiate the atrium morphologically, right? So we wouldn't have to review that. Situs inversus, what does that mean? Right, now you have a clue of that when you look at the abdominal organs because you will notice that the liver is on what side? The liver would be on the left side, right? Situs ambiguous, that's that condition that's associated with heterotaxy. What are the syndromes there? Asplenia and polysplenia. So when we look at the atria with somebody with polysplenia, right, the morphology of both atria resemble what? What kind of atria? Left-sided atria, right, which means they usually have, how do you differentiate a left atrium from the right atrium? What does the left atrium have? The tubular atrial appendage, right?
So the morphology resembles left-sided atria when you talk about polysplenia. Asplenia, the morphology of both atria resemble right-sided atria. All right, so that's the situs. Then we look at the atrioventricular connections, right? Is the morphologic right atrium connected to the morphologic right ventricle? We call that atrioventricular concordance, right? If the morphologic right atrium is connected to the morphologic left ventricle, we call that atrioventricular discordance, right? Look at ventricular morphology. So where is the right ventricle, of course, relative to the left ventricle? You need to figure that out. You need to know the morphology of the ventricles, right, to figure out the atrioventricular connections. Where is the when you've decided where the morphologic atria are, you need to decide where are the morphologic ventricles, what side are they on, and which ones are connected to what in terms of, where's the morphologic left ventricle, what atrium is that connected to? The ventricular situs, when we think of ventricular situs, this has to do with the looping of the heart, right? Which way did the heart loop embryologically? Now we can tell that. Are they D-loop ventricles versus L-loop ventricles, right? Usually with D-loop ventricles, the right ventricle will be to the right of the left ventricle. With L-loop ventricles, it's the reverse. The right ventricle, the morphologic right ventricle, will be to the left. Your choices there are D-loop, L-loop, X meaning we can't tell, okay? Most cases you're going to be able to decide if it's D-loop or L-loop. The chamber positions, the ventricular arterial connections, are they concordant or discordant? Now, when we say, what's our terminology for the relation of the great arteries? Normal, inverted, D transposition, L transposition, or malpositions, right? Normal, of course, the normal relationship of the pulmonary artery to the aorta is?
Anterior superior to the
Anterior and to the right or left?
to the left.
To the left, right. That's the normal relationship, okay? Inverted relationship is the mirror image of that, in that the pulmonary artery is still anterior, but it's to the right. Detransposition, right? So here we have ventricular arterial discordance. Usually when you have transposition, which vessel is anterior? The aorta or the pulmonary artery? The aorta, right. And with detransposition, it tends to be to the right of the pulmonary artery. Again, with transposition, the aorta tends to be anterior to the pulmonary artery, but with L transposition, it tends to be to the left of the pulmonary artery. Now, that's a shortcut. The D and the L kind of does give you an indication of whether the aorta is going to be to the right or to the left of the pulmonary artery. But the D and the L here do not specifically refer to the position of the aorta. The D and the L here refer to what? The cardiac looping in embryology. Right. But it's a nice shortcut that it tends to coincide with the position of the aorta. Okay? And then we will look at associated anomalies, septal defects, pulmonic stenosis, atrial defects, VSDs, etc. Right? So the shorthand nomenclature for this, there are three parameters that you will decide and you will put in shorthand in terms of your report. You have the situs, the loop, the great vessel relationships. And that shorthand kind of describes in a very succinct fashion summarizes what the abnormality is. So it's easy for the referring physician to understand what you're talking about. And, we've kind of gone through all of this already. So the shorthand, the situs, the loop, the great vessel relationship. For visceratrial situs, S is the abbreviation for solitus, I is the abbreviation for inversus, A is the abbreviation for situs ambiguous. For ventricular loop designation, D is D-loop ventricles, L loop ventricles, X can't tell. Okay? And then for the great vessel relationships, S is the abbreviation for solitus, meaning normal, right? Remember, normal relationship, the pulmonary artery is the anterior to the left of the aorta. I, inverted, which is the mirror image of normal. So there, the pulmonary artery is still anterior, but it's to the right of the aorta. And then we have detransposition, and L transposition. Okay? So normal, if we had to summarize, what is normal in this type of summary, okay? Well, normal, we have situs solitus, right? Right atrium's on the right, left atrium's on the left. D-loop ventricles, right? And then you have a normal relationship of the aorta and the pulmonary artery. So S for situs solitus, D for D-loop ventricles, and S for situs, or that normal relationship of the aorta and the pulmonary artery. So your abbreviation for the normal configuration would be SDS. What about somebody who has situs inversus totalis? Well, they have situs inversus totalis. The left atrium's on the right side, the morphologic left atrium, the morphologic right atrium's on the other side. They form L-loop ventricles, right? So we have I for inversus, L because they formed L-loop ventricles. And then the relationship of the great vessels here, pulmonary artery will still be anterior, but will be to the right of the aorta, the mirror image here of normal, I for inversus. So the abbreviation for situs inversus totalis would be ILI. Okay. So to get an idea of what the situs is, remember, if you look at the heart, things can be very confusing in some of these complex conditions. You want to start with the abdominal organs. That's usually most obvious, easiest to figure out, because the atrial situs usually follows the visceral situs. So even though this heart looks very confusing, right? If I look at the organs here, this guy, of course, is and that guy is so what's the situs here? Solitus. So when I look at the heart, this is an atrium here, this is another atrium there. This atrium I would expect to be the morphologic right atrium. This atrium I would expect to be the morphologic right. So that's how we determine or get an idea of what do we think the situs of the atrium are going to be. Also important to follow the IVC, because the IVC takes you to morphologic right atrium. Yes. Now, for figuring out the ventricular looping, von Praagh came up with this hand rule for determining ventricular looping. In most cases, this is not necessary, but sometimes these hearts can be reoriented in space. They're not sitting there in a nice, easy way to figure out. And when that happens, then this can be handy. So the D-loop morphologic right ventricle is right-handed, so how do we do this? All right, you're looking at a CT scan, right? So this, I'm going to tell you, is the morphologic right ventricle here in this particular patient. Right? This is a normal case, right? There's the morphologic right ventricle. We're looking at a CT scan, so the conventional way of looking at a CT image, patient is lying on their back, the feet are coming, which way the feet are coming? Towards you, right? Now, how do we look at a CT image, right? Patient's lying because this is the right, this is the left. The feet are coming towards you, right? The patient's head is behind the board. Do we understand that? Yes? Okay. So to figure this out, we place the palm of the right hand on the septum, and we see if the thumb aligns with the inflow and the fingers through the outflow. What does that mean? Well, if we're looking at a CT image, right, will the pulmonary artery be on this side of the board or behind the board? It would be behind the board, right? Because the head is back there. It's cranially located relative to the ventricle. You can also follow it on your axial images, and you could tell. So if you take your right hand and put the palm on the on the septum for this morphologic right ventricle, the thumb does indeed align with the inflow, right? And the fingers align with the outflow. So that is a D-loop heart. All right, that's the shortcut for, again, most times you won't need this, but there can be cases where the heart can be very twisted there, and you might need this to figure it out. The D-loop left ventricle is left-handed. I mean, you'd have to you can't take your right hand and put it on that left ventricle to get the thumb to, put the palm on the septum to get the thumb to align with the inflow and the fingers. So the only way you can do it is with your left hand. See? So it's one way to figure out a D-loop heart. Now, when we look at the abdominal organs here in this patient, we see what? Situs inversus. So here are the atria, okay? So this atrium we would expect to be what? Morphologic what?
Right.
Right atrium. This atrium we would expect to be, right, morphologic left atrium. So I'll tell you that this is a morphologic right ventricle, right? And that is a morphologic left ventricle, okay? So this heart forms from an L loop. It's a patient with situs inversus totalis here, right? The L loop right ventricle is left-handed. If we went through the same exercise, to be able to put my palm on the septum and my thumbs aligning with the inflow for this ventricle, and from my fingers then go through the pulmonary artery or whatever the outflow is on the other side, I can only do that with my left hand. Right? So that tells me that this is an L loop heart, or L loop ventricles, right? These ventricles form from an L loop, okay? Now, we also said there was a shortcut. If you look at the aorta and the pulmonary artery, right, that also gives you a clue. Fortunately, that tends to help us too. All right. So the D-loop morphologic right ventricle is right-handed. With the L-loop, when you have L-loop ventricles, the L-loop morphologic right ventricle is left-handed. That is the von Praagh rule for figuring out the looping of the ventricles. All right. So we look at this case. Gee, things look really funny here, right? So what is going on? Let's take a look. So we like to start with what? When we look at first, let's look at the abdominal organs, right? Forget the lymphadenopathy. Look at the abdominal organs, right? What would we say about the abdominal organs in this patient?
Solids.
Yeah, so it looks like the liver's on the right, looks like the spleen is on the left, so we expect this patient looks like this is solitus, right? Now, we like to start with what? IVC, and we're going to follow that, and it's going to take us to where?
Atrium.
Okay, so we expect that will be then the morphologic
Right atrium.
right atrium, right? And then the guy on the other side will be a morphologic
Left.
left atrium, right? Any problems with that so far? No. Now we have ventricles, right? So can you figure out the morphology of the ventricles, right? Morphologically, what kind of ventricle is this? Do you think it's a morphologic right ventricle? Why?
You said moderator band.
Okay, so you see a moderator band. Also, the inflow and the outflow are separated, right? If we look at the other side, look at this guy, here's the inflow, there's the outflow, right? So that's a morphologic left ventricle. So if we talk about now the atrioventricular connections, are they concordant or discordant? Concordant. You have a morphologic right atrium connected to a morphologic right ventricle. You have a morphologic left atrium connected to a morphologic left ventricle. Right? Well, now let's look at the outflow. That morphologic right ventricle, this guy, is connected to what? Pulmonary artery. Okay? The morphologic left ventricle here is connected to what? Aorta. So the ventricular arterial connections are concordant. Now, what is the relationship of the pulmonary artery to the aorta? To the left and anterior. That is normal. Right. So we have situs solitus. Well, what is our situs here, right? Our situs is which one of these three? S, solitus. The cardiac loop is, well, you kind of have an idea because everything looks normal, but if we went through the exercise to figure it out, we said this was a morphologic right ventricle, right? So when you take your right hand, does the palm go on the septum? Does the thumb align with the inflow, and will the fingers align with the outflow? Yes. So what kind of loop is that? D, right. So for our cardiac loop, we're going to pick D. For the great vessel relationship, we notice the pulmonary artery here, it's concordant. The pulmonary artery is anterior to the left of the aorta. So for the great vessel relationship, we would pick what letter? S. So this is normal, right? So why did everything look weird on the chest X-ray then? Yeah, well, there's elevation of the left diaphragm, the stomach's elevated, that's just pushing the heart to the right. All right, so it's really no congenital heart disease here. It was just the problem with the diaphragm. You have an elevated diaphragm here that's pushing everything to the right, maybe some eventration, right? So we have a normal heart displaced to the right. We call that dextroposition. Okay? No congenital heart disease in this patient. And the abbreviation here would be SDS. All right, look at this X-ray. Things look a little funny now, right? So the first thing is, figure out do you have an idea what the situs of this patient might be? Where do you look to figure out, to get an idea from the X-ray? Where do you look on the X-ray to get an idea of situs?
You're saying the visceral color stage.
You look at the abdomen, right? So when we look at the abdomen, what might we say? Where do we think the liver is?
On the left.
Yeah, so we might suspect that the liver's on the left side here, right? And we would call that inversus, right? So we have some inkling that we might have situs inversus here, okay? The apex of the heart looks like is on what side? Right side. What term do we use if the apex is on the right side? We call that dextrocardia. Right, we call that dextrocardia. Okay? So this patient certainly has dextrocardia. We suspect there might be situs inversus. All right. So when we look at the abdomen here, what's our situs? Yeah. So the liver's here, the spleen's there. All right, so now what are we going to look at next? We're going to look at the
IVC.
Okay. Whoops. So let's play it. So we follow the IVC, right? So when we follow the IVC here, this guy, it takes us to this chamber. So what chamber would we expect that to be?
Morphologic right atrium.
Morphologic right atrium. Yeah. So then the chamber on the other side, the atria on the other side, we would expect to be the morphologic left atrium. Yeah. So that's morphologic right, that's morphologic left. Now we have to figure out the ventricles. Okay? So the anterior ventricle here, what do you think is the morphology of the anterior ventricle when we play it through? So this ventricle right here, right? What's the morphology of that ventricle? Why do you say it's the right ventricle?
It's the moderator band.
Yeah, because you see a moderator band there, and there is separation of the inflow and the outflow, right? The posterior ventricle here, okay, the morphology of that is going to be then a morphologic left ventricle, okay? Now, the connections here, right? So so the morphologic right atrium, which you said is this guy, is connected to a morphologic what? Right ventricle. The morphologic left atrium is connected to a left ventricle. So what do we call that? Atrioventricular concordance. Now we want to look at the outflow, right? What is the ventricle connected to? So this morphologic right ventricle here is connected to what? Pulmonary artery, okay? And then when we'll look at the posterior ventricle there, which we've said is a morphologic left ventricle, okay? This morphologic left ventricle here is connected to the aorta, okay? And here, what's the relationship of the pulmonary artery to the aorta? Yeah, it's inverted. It's still anterior, but instead of being to the left, it's to the right. So now when we go through all this, the situs is what? High. The cardiac looping, again, let's look at, we've said here's our morphologic right ventricle. If we have to figure out the cardiac looping here, right, using our hand rule, which hand can we place on which hand would you have to use to put the palm on the septum, your thumb to align with the inflow, fingers to align with the outflow? Which hand would you have to use to do that? You'd have to use the left hand. So the cardiac loop is L. Great vessel relationship? I. So your abbreviation for this case would be? Okay. So the right ventricle is the anterior, goes to the pulmonary artery. Here's your posterior ventricle, it's the left ventricle. Nice here that you could see that the inflow and the outflow are connected here. So that's a morphologic left ventricle. Here's the inflow, there's the outflow, there's the aorta. So ILI, this is a patient with situs inversus totalis. Okay. Notice that the anterior descending coronary artery here comes from the right coronary artery. It's the mirror image of normal. Right? Usually the anterior descending comes from the left coronary artery. That's the mirror image. Having said that, though, the coronary artery anatomy, it turns out, follows the ventricular looping, not the situs. Right? So the coronary artery anatomy tends to be the mirror image, not because it's situs inversus, but because it's an L loop. So the coronary artery anatomy follows the looping of the ventricles, not necessarily the situs of the atrium. Okay? All right. Whoa. All right, this one. Look at this. We look at this X-ray, right? So somebody looking at it might say, okay, well, this patient obviously has situs inversus, right? I mean, it's just a mirror image. Is that right? Why not? Yeah, so the liver's on the right, but the stomach here is on the left. So we would suspect that the situs of this patient would be what? Situs. But the apex here is on the right side, right? What do we call it when the apex is on the right? We call it dextrocardia, right? So if we have dextrocardia with situs solitus, we talked about the term for that. What was the term that we used if you have dextrocardia for situs solitus? Dextroversion, right? Well, we have a problem here. We're going to have to figure things out, okay? It's not just a simple case like we just saw before of somebody with complete situs inversus. There's something else going on here, okay? And you can tell that just looking at the abdomen, just looking at the X-ray. All right, so let's go through it. We look at the abdominal organs, right? So we suspect the situs is here. What's the situs? Solitus, right? So what are we going to find? IVC. And we expect that's going to take us to what? Right. So this guy would be what? Morphologic right atrium. This guy on the other side would be morphologic left atrium. Okay? So notice the morphologic right atrium is to the right of the morphologic left atrium still, right? Which is what you would expect in somebody with situs solitus. Now we have to figure out the ventricles, okay? So this posterior ventricle here, what do you think is the morphology of that posterior ventricle? Or you can pick the anterior ventricle. Tell me what you think the morphology of the anterior ventricle is. What do you think is the morphology of either one of these? So pick one. Tell me which one you want to pick.
The one with more posterior is the right ventricle.
Okay, so you believe that this ventricle here is a morphologic right ventricle. Okay? Why do you say that?
You see the moderator band.
Moderator band. And is there separation? There's the outflow there. We saw the inflow was down lower. So there seems to be separation between the inflow and the outflow. So that would make that a morphologic right ventricle. The anterior ventricle, okay, the morphology of the anterior ventricle, you think is what? Morphologic left ventricle. Why do you say that? Because if you look at the inflow, right, it's very closely connected to the outflow. They're very close together. So that looks like a morphologic left ventricle. So the morphologic right atrium is connected to a morphologic right ventricle. The morphologic left atrium here is connected to the morphologic left ventricle. What do we call that? Atrioventricular concordance. Now let's look at the outflow, okay? So we can start with the morphologic left ventricle there. So this morphologic left ventricle is connected to what, as far as outflow? The aorta, right, there it is. And that posterior ventricle that we said was a morphologic right ventricle, right, this guy over here is connected to, that guy is connected to pulmonary artery. So we have ventricular arterial concordance, okay? So situs is what? S, right? Situs is S. Now the cardiac looping, we said this was a morphologic right ventricle, right? So what's the looping of this heart then? Still D, right? Because you can, if you take your right hand, you can put the palm on the septum. Your thumb will align here with the inflow, and your fingers point through the board. Remember, the pulmonary artery is going to be cranial, is going to be located behind the board, right? So that cardiac loop is a D. The great vessel relationships here, well, the pulmonary artery, right? Is it anterior or posterior to the aorta? Anterior, right? You can see here, right? Is that in a normal relationship? Is it to the left or to the right of the aorta? It's to the left. So that relationship then, the letter we would use there is S, right? Whoops. So surprisingly then, so here's our heart, right? That's what it looks like in 3D. We have situs altus, D loop ventricles, normal great artery. We have dextrocardia. We have dextrocardia with situs altus, so we have dextroversion. In this particular patient, there were no other congenital anomalies. This was the only congenital anomaly that this patient had. It's kind of rare. So here's our posterior ventricle, right? And you can see the inflow and the outflow very closely connected. I'm sorry, this was the anterior ventricle. This is the morphologic left ventricle here, and then here's your morphologic right ventricle, which turns out to be the posterior ventricle. So it looks like, I mean, if you take this heart and turn it this way, it would look normal, right? So it looks like you took this heart and just twisted it this way, and that's why this term dextroversion comes into play. It looks like, oh, the heart twisted abnormally, but we went through the embryology. It's not that it twisted abnormally. In this particular case, it just didn't migrate to the left, which is the way what it was supposed to do with a D-loop heart in situs altus. Okay, so SDS for this patient, and there it is. If we turn it the other way, it would appear more normal to us. Okay. All right, now what about this guy? Just looking at the images, deceivingly, this looks normal, right? You're just looking at these, but if we start to analyze it, what's the situs here? S, because the liver is on and the spleen is on the left, right? So this atrium here, you would expect to be a morphologic. What kind of atrium would that be? Left, because you said that we think the patient has situs altus, we would expect that to be a morphologic left atrium. This atrium we would expect to be a morphologic right atrium. Now, what about the ventricles? What kind of ventricle is this? What's the morphology of this ventricle?
It's one image I was thinking.
What's the morphology of this ventricle? What is this guy?
Oh,
So what's the morphology of that ventricle? That's a morphologic right ventricle, right? So you'd expect this to be a morphologic left. The atrioventricular connection is what? Discordant. Okay. Now let's look at the outflow. Okay. This ventricle, right, which we said is a morphologic right ventricle, is connected to this guy. And this guy is the aorta. This ventricle, which we said is a morphologic left ventricle, is connected to this guy, which is pulmonary artery. So the ventricular arterial connections are discordant. Yeah. And now the relationship here of the aorta to the pulmonary artery, what's the relationship there of the aorta to the pulmonary artery? Yeah, it's to the left, but there's transposition. It's anterior. We know there's transposition. This is an L transposition. Okay? So we have atrioventricular discordance and ventricular arterial discordance, right? So we call this whole thing, we call it what? What kind of transposition is that? When you have both atrioventricular and ventricular arterial discordance, congenitally corrected transposition, right? So if we go through this, we have situs solitus, we have L-loop ventricles, L transposition, it's corrected transposition. So S for situs solitus, L for L-loop ventricles, and L transposition. Now, if we go through the exercise for the ventricular looping, right? Here is our morphologic right ventricle, okay? Which hand would you have to use to put the palm on the septum, your thumb to align with the inflow, and your fingers to align with the outflow? Which hand would you have to use to do that? Left. So that's an L-loop heart, L-loop ventricles, okay? So this is a case of congenitally corrected transposition. But they have situs solitus, in this case, with dextrocardia, right? So we call that situs solitus with dextrocardia. We call that, what did we call that? Dextroversion, right? It's a patient with dextroversion. Okay, so here, look at this heart. What do you imagine the situs to be here? Well, if you look at the abdomen, right, you always want to start with the abdomen. What do you think the situs might be? Where do you think the liver is? Well, there seems to be some bowel up here, so we might suspect the liver is on the left, which would make it inversus, right? Situs inversus. The apex is here, right? So somebody might suspect, okay, so we have somebody with situs inversus, and the apex is on the other side. That's what we would expect, right? So maybe this person has situs inversus totalis. Reasonable? Okay, let's take a look. Okay, the situs is what? Inversus. Here's the liver, there's the spleen. So we're going to find, what are we going to find? IBC. And that's going to take us to morphologic right atrium. So you'd expect this guy to be the
Morphologic left atrium.
morphologic left atrium. Okay? Now we want to look at the ventricles. Okay? So we see that morphologic left atrium there. So let's find that. So we said this was our morphologic
Right.
right atrium, yeah. So, and we said the other side we have the morphologic left atrium. So that morphologic left atrium, what kind of ventricle is that connected to? Let's see if we can figure that out. So we'll go through this again. So here's our morphologic left atrium. What kind of ventricle is this? What's the morphology of this ventricle? Is there separation of inflow from outflow for that ventricle? Does that ventricle have an infundibulum? Let's see. So here's the ventricle, there's the inflow. What do you think? Can you tell? Well, look at let's look at the other side then. Look at the other side. So look at the other ventricle. This ventricle over here, right? There's the inflow. There's the inflow there. There's the outflow.
Okay, so the morphologic left atrium is connected to the morphologic right.
Well, which ventricle is the morphologic right? Which ventricle is the morphologic left? Is the anterior ventricle a morphologic right ventricle or a morphologic left ventricle? The anterior ventricle. Okay, so the anterior ventricle here is a morphologic left ventricle. The inflow and the outflow are not separated. So the anterior ventricle is a morphologic left ventricle. There's the inflow, and then there's the outflow. Very close. Here there's an infundibulum. You see there's musculature on the other side separating the inflow from the outflow. So the anterior ventricle is a morphologic left ventricle. Okay? So we said here that the atrium, we said that this was what kind of atrium over here? Morphologic right atrium is connected to a morphologic left ventricle. It's the opposite of this. So that is atrioventricular discordance. Okay. Now we need to look at the outflows from the ventricles. Right. So our anterior ventricle, which we said is a morphologic left ventricle, right, is connected to what? Let's see. So the anterior ventricle, which we said is a morphologic left ventricle, there it is. What is that connected to? Pulmonary artery. Okay. The posterior ventricle, which we said was a morphologic right ventricle, let's see if we can see what that's connected to. Here's your posterior ventricle, which we said was a morphologic right ventricle. That is connected to, here it comes, the aorta. So we have ventricular arterial discordance, right? So the patient has, what do we call that? If you have ventricular arterial discordance, you have what? You have transposition. Right? So there's atrioventricular discordance and ventricular arterial discordance, right? We call that combination of things congenital corrected transposition. So let's go. Situs, what's the situs? I. The cardiac looping, let's see if we can figure that out. We said, what kind of ventricle did we say this, well, I guess we could start with your right ventricle, right? We said this was a morphologic right ventricle, right? So what kind of looping would this have to be? D, right? To be able to be able to put your palm on the septum, your thumbs to align with the inflow and your fingers to align with the outflow, that would have to be D loop ventricles. The great vessel relationship here, right? We said that there's transposition. The aorta is on the right of the pulmonary artery here, right? But it formed from a D loop, you know that. So this is D transposition. So this is somebody with congenitally corrected transposition, but it's a D transposition because the patient has situs inversus. Do we understand that? So situs inversus, D loop ventricles, D transposition, but in this case it's congenitally corrected. Extremely rare, inverse ID transposition, because two things have to go wrong for this. You have to have both situs inversus and a discordant cardiac loop. So this is extremely rare, much rarer than congenitally corrected, the usual case of congenitally corrected transposition that we saw earlier, because here two things have to go wrong, right? Now the only way you could figure this out is if you went through the exercise that we went through. Okay, you might also have an inkling when you look at the aorta and notice why is that aorta anterior? Okay. So situs inversus, D loop ventricles. So even though the patient has situs inversus, notice here that the left coronary artery gives rise to the LAD. So that's kind of the normal coronary artery anatomy, even though the patient has situs inversus. That is because the coronary artery anatomy follows the ventricular looping. It doesn't follow ventricular situs. And because this heart went through a D loop, the coronary artery anatomy follows the normal looping. Interesting question. Can you make the diagnosis from the plain film? Well, we have an inkling that the patient has situs inversus, right, when we look at the abdominal organs. The question is, can we tell where the ascending aorta is, right? If you look at the plain film, do you have a clue where the ascending aorta is? So look at the mediastinum here, right? There's this thing coming up, which turns out to be the ascending aorta to the right of the pulmonary artery, right? And we said that if the ascending aorta is to the right, or if the aorta down here is to the right of the pulmonary artery, right? That usually goes along with a D loop heart, right? So if the patient has situs inversus and formed a D loop heart, that is a discordant cardiac loop. And discordant cardiac loops, we said, give rise to congenitally corrected transposition, right? So you might be able to take a guess at that from the plain film that this patient's going to have congenitally corrected transposition. Okay, very strange looking chest radiograph. The first thing you notice when you look at the vascularity, we notice what? What are these guys? Yeah, those are really big pulmonary arteries. So we suspect the patient has what? Yeah, pulmonary artery hypertension. Let's see if we can figure out what's going on. Okay, now we like to start with situs. What do you think looking at this? What? Any? Well, let's play it. So, what do we want to start with? What is it you want to follow? The IVC. Because the IVC is going to take you where? The morphologic right atrium. Where's that going? Where did that IVC take you to? So let's go through that again. Right? There's the aorta. There's this guy here. That's what we think is the IVC. Where's it going? Well, is that going to a morphologic right atrium? No. It's going to that guy over there. Yeah, it looks like, well, I mean, that's look like it's up there. That's the venous return. Very strange. Okay. You notice on the right side, yeah, you have multiple spleens there on the right side. So you're suspecting this patient has, what do we call that? You said it,
Polysplenia.
polysplenia.
Yeah.
Now, the reason the IVC doesn't help you with polysplenia is because polysplenia is associated with what? Yeah, but what about the IVC? Polysplenia is associated with azygous continuation of the IVC, which is kind of what's happening here. Okay, so when we try to look at the heart, when we try to look at the atria in this case, first of all, there's a big, what's missing there? Yeah, the whole septum is missing. So you have a big atrioseptal defect. All right, what kind of shunt will that give you? ASDs give you what kind of shunt? Left to right. Now, when you look at the ventricles, just looking at this case also, we notice, when we look at the ventricles here, what's missing here? Yeah, that part of the septum is missing also, right? So there's a big VSD. So what do we call it when so much of that is missing there? That atrioseptum, the ventricular septum. You have this giant hole in the center of the heart where all the chambers are communicating. What do we call that? Endocardial cushion defect, right? So this patient has a very large endocardial cushion defect, a complete endocardial cushion defect, and we can tell that just looking at this. And that's why, your pulmonary artery, there's also atherosclerotic disease in the pulmonary arteries in this case, because of the severe pulmonary hypertension in this case, right? But from what we have so far, right, the situs, we think this patient has, which of those? Which of those would we say? Well, if we look at the atria, right, big atrioseptal defect, right, what does that look like here? That looks like what? Yeah, that looks like a left atrial appendage. What does this look like? Same thing. That also looks like a left atrial appendage, right? So both atria here resembling morphologic left atria. So the situs here would be, yeah, so the situs here would be ambiguous, okay? I mean, we could go through the whole exercise of the cardiac looping and the great vessels and all of that, but in this particular case, we already know that it's going to be polysplenia, big left to right shunt because of this because of this big endocardial cushion defect, bilateral left-sidedness, so it's a patient with situs ambiguous. And then if we look at the lungs, here's the right lung, here's the left lung, okay? What is this guy? What is that? Major fissure, right? Major fissure. So both of these lungs, missing a minor fissure here, right? Both of these lungs are bilobed lungs. And so even the lung morphology here resembles bilateral left-sidedness, okay? So we have polysplenia, common atrium, common AV valve, bilateral hyperarterial bronchi, azygous continuation of IVC. This was a patient with polysplenia syndrome. And this azygous continuation of the IVC. If you go through the exercise, it's going to be ambiguous. It's going to be an L-loop heart, and it turns out that the great vessel relationship in this particular case are inverted. But it's somebody this is a case of polysplenia, okay? So what we've gone through here are some various causes of dextrocardia in adults. We saw situs inversus dextrocardia with L-loop ventricles, situs inversus totalis, situs solitus with dextrocardia, D-loop ventricles, dextroversion, situs solitus, dextrocardia, L-loop ventricles, corrected transposition, dextroversion, situs inversus, dextrocardia with D-loop ventricles, corrected transposition, and polysplenia syndrome. So these are all the cases that we've gone through. I'm not going to go through them again, but these were all different variants. These are all different things that can give you situs, that can give you dextrocardia in adults, all of these. And the only, most important way to tell them apart is to go through the exercise that we went through, okay? So in summary, to determine the situs, you're going to look at the heart last, right? look at the organs, look at the visceral situs, because the atrial situs follows the visceral situs. So is it situs solitus, is it inversus, or is it ambiguous? Follow the IVC. The IVC will take you to the morphologic right atrium. Determining the ventricular morphology, once you determine the ventricular morphology, you could figure out the cardiac looping. We went through the exercise of the von Praagh right-hand rule for figuring out the looping. The atrioventricular connections, are they concordant or discordant? Ventricular arterial connections, are they concordant or discordant? We went through the great vessel relationships and the abbreviations, S for normal, I for inverted, D and L transposition. And then lastly, you look at for associated anomalies, ASDs, VSDs, pulmonic stenosis, etc. Okay? So that is our discussion of cardiac malpositions. Any questions? Okay, very good.